We could discuss a lot of things today, but you know, we don't have time. We have 1 hour and a half. So with the committee here, with the panel, we decided to focus on 3 main topics. We know that fractures are some issue, but not very specific from handball. So we will talk about throwing pathology. Obviously, it's something that we need to discuss. Anterior shoulder instability, and you will have some surprise, I'm sure. And we would like to focus as well on the acromoclavicular disjunction, which is something which happens frequently, and it's an acute lesion usually, and it's something that we would like to discuss as well. So these 3 topics will be the outline of our presentation. The second question of the diagnosis is to know what treatment. And to be honest, each time you ask which treatment, if you're in the field of sport, it's always, is it physiotherapy or is it surgery? And you can talk in different way. At the end, it's always the same question. Conservative, it means usually physiotherapy or surgery. Do we have to do surgery or not? Do we have to do a conservative treatment? Do we have to do immediately surgery to avoid the patient lose time, or do we have to wait and to start first the conservative treatment? We will try to answer to this question. So to answer to this question, I tried to bring 3 musketeers, because I'm French. So, and these 3 musketeers, but they are quite bizarre because they're not like in the Alexandre Dumas books, because the first musketeer by order in this presentation is an Australian musketeer, which doesn't exist normally, and is Rodney Whiteley, who is working in Aspetar. And this physiotherapist, PhD, has a huge experience. You will see he will do an amazing presentation. He has a very good experience, excellent experience and expertise in baseball, and now he's interested in handball, so he can compare the 2 pathology, the 2 sports, and he will bring us a lot of input from the baseball. The second musketeer is a true musketeer. He's a French musketeer from the north of France. He's the president of the French Arthroscopic Society. He's a well-known, even famous shoulder surgeon in France. And he will develop and he will talk about the shoulder instability with his huge experience as well in different sports. And finally, and which is surprising, the third musketeer is a musketeera, because she's a lady, and probably Alexandre Dumas will not be happy about that, maybe yes. And Florence is a physiotherapist, and she has large experience, practical experience in different sports, and she will show you how practically you have to treat and to manage the acromoclavicular joints. So you see these 3 musketeers, it means 2 surgeons and 2 physiotherapists, and this is exactly what we want. Do we have to do physiotherapy? Do we have to do surgery? And this is, we hope that we will try to, and at least we will try to answer to some questions. This is the outline of our presentation. Rodney will start with the evaluation and conservative treatment of throwing shoulder injury. I will do a small presentation about surgery management. Why small? Because it's not the main treatment, and so I will leave Rod maximum of the time. Anterior shoulder instability will be treated by Olivier Courage, and then we will talk about acromoclavicular dislocation. Let's go, Rod.
Very much, Philip. I need to go quite quickly today, so please be aware that the presentations will be recorded. We'll make the slides available later for everybody, and we'll probably also make a journal article in the Aspetar journal. So if you aren't already a subscriber, please make sure before the conference is over you become a subscriber. So don't worry about writing everything down so much. And if I go too fast, stop me later and ask questions. So here's the overview of what I want to talk about. Firstly, I want to discuss some aspects related to the culture of handball and why this is important when we think about the kinds of injuries that we look at. I then want to develop the idea that in the throwing shoulder, there is no anterior instability, and why this is such an important thing for us in our management and prevention of this injury. After we understand this, we'll go through the key examination and treatment points, and we need to understand the difference between injuries related to the deceleration phase of throwing, and because these don't cause time loss, they get ignored by handball players, but they lead to the injuries that we have much more difficulty treating. At the end of that, this is going to be the main part of the talk. We'll speak very briefly about what to do when your treatment in the clinic is finished, and then when to decide, no, conservative treatment isn't going to work and we need to refer on. So prior to coming to Aspetar 5 years ago, I lived and worked in Sydney, and for those 20 years, the sports that I worked with were mostly rugby and baseball and a little bit of football. And working with rugby and baseball has given me, I think, a good preparation to come and work with football. Baseball pitchers at the highest level are the best throwers in the world. Their whole sport, the success of their sport, purely comes down to how well these guys throw. So the culture of that sport is the smallest injury, the smallest problem that you have, you come and tell the physio, the doctor, the trainer about it. Rugby league and rugby union is a collision sport, and the culture of the sport is very different to football. And so I think that the nature of handball is much more akin to what I've seen in rugby league. Now the main difference here is, in this sport, it's a collision sport, and if I don't do my job, not only do we lose, but my teammate gets injured. And this is the case as well in handball, in that this is a collision sport, all the players are injured all the time, but the culture is, I don't tell people about this because this is normal in this sport, and it contrasts a lot with what we see in football. I prefer this sport. So, why we need to explode the myth of anterior instability. How this came about is understandable. Players will tell you, it hurts when my arm is in this position. Well, that's where anterior instability happens, so likely it's anterior instability. And then the relocation sign is positive on these guys, so clearly it must be an anterior instability is what's going wrong. Why we should have known that that isn't the case is on this spectrum from anterior instability up to cuff and slap lesions, this is what we see in the throwing shoulder. When you do this test, they tell you they have pain. Somebody with instability will tell you, stop because my shoulder's going to dislocate. Or they'll tell you that their shoulder actually came out at some stage. And this is never the case with throwing injuries. Okay, so then the argument is, well, maybe it doesn't completely dislocate, but there's this continuum of micro-instability somehow, that maybe the shoulder is coming a little bit forward and that's what's causing all the damage. Now, my argument against that is, if this is the case, then it should be a continuum. Some people will sublux only a small amount, and some people should sublux a lot. Now, if this is the key feature of the throwing-related injury, then we should have an over-representation of some people whose shoulders actually come all the way out forward and dislocate. If we look at this, and so this is some comparative data that we published in one of the shoulder surgery journals. In the skeletal data, in a series of 500 skeletons, Edelson's group found about 5%, 24 of those, had evidence of bony dislocation, bony Bankart or a Hill-Sachs lesion. So the prevalence in the general population for shoulder dislocation seems to be about 1 in 20. Of course, not all of these people go to the hospital, so Hevelius' series of about 2,000 hospital visits showed only about a third of that, 35 or so if memory serves, 1% actually go to the hospital and say, my shoulder dislocated, can you do something about it? So the normal rate of shoulder instability in normal people is somewhere around here. Cricket's a sport played in the former colonial British countries where it's important to throw, but it's not central to the game. It helps to be a good thrower, but you don't have to be a good thrower to play. So we can think of these guys as being slightly above average throwers. The incidence of anterior dislocation in the throwing shoulder in cricket players is less than half, maybe a fifth of what is normal. We collected some data on 2,500 professional Major League Baseball pitchers and found the number of reported injuries of anterior instability in the throwing arm of Major League Baseballers, and it was 0. So what I'm saying is, the better you are at throwing, the less likely in your throwing arm are you to get an anterior instability. The pathology is not anterior instability. So what is it? There's actually a lot of evidence now in vitro, in vivo, imaging studies that tell us about this. I've only got time to talk to you today about one of them, But this paper put some people into an MR machine with their arm by their side and their arm at 90 degrees of abduction external rotation. And in that position, they looked at where the humeral head went, both in terms of its contact point and where the centre of the head of the humerus was relative to the anterior and posterior aspects of the glenoid. Now in the control group, and these were mainly people with cuff tears, with their arm by the side, the head of the humerus sat more or less centred. It wasn't anterior or posterior. When they went into abduction and external rotation, it went posteriorly by about 1 millimetre. For the people with the slap type pathology, the throwing type pathology, again, by the side, it sits centred. But in abduction external rotation, it goes posteriorly. And it goes posteriorly 3 times as much as normal people do. So if there is an instability, a subluxation, a translation associated with the throwing shoulder, it's posterior, not anterior. So how does this happen? To understand this, we need to go back 25 years to Steve O'Brien's award-winning paper which documented the anatomy and the histology of the inferior band of the glenohumeral ligament. So this inferior band, all of us of course have heard about the anterior band of the glenohumeral ligament, the anterior inferior, but given much less attention is the posterior band, which turns out is just as big and just as thick. Here it is on the histology slide. So this part of the throwing shoulder is what we speculate to be the problem related to this posterior-superior translation. And how this works is a little bit unusual. We need to consider it in context of what's happening during shoulder rotation. And again, this was Steve O'Brien's work, who said that the capsule acted like a hammock underneath the head of the humerus. So as you rotated, the hammock stayed with you, and this allowed the head of the humerus to stay centred inside the socket. But of course, the position of the hammock changes according to the amount of rotation in your shoulder. So how it happens in the throwing shoulder is this posterior-inferior band. During abduction and external rotation, the posterior-inferior band wraps underneath the head of the humerus, so it actually ends up anterior and inferior. And if that posterior band happens to be tight and thick, then it's going to actually sling and pull the head of the humerus posterior-superiorly. And this is the essential lesion of the throwing shoulder. How does this happen? This is where we're speculating a little bit. Try and figure out which guy's going to injure his shoulder here. These guys both throw at the same velocity, but this guy, because when he lets go of the ball, the deceleration phase is abbreviated. So all of that force he built up during the acceleration phase, he now has to stop over a very short period of time. Now, why this is such a big deal in handball throwers is they can't land and follow through on the ground, because the majority of the hard throws they make, they're in the air. And if they did this, they'd land on their face. So their follow through has to be just at their arm, and they can't use their body and trunk to do it. So the pathology, Dr. Landreau is going to talk more about it, but in essence, it's a posterior-superior undersurface cuff fraying associated with a slap lesion. I think Gilles Volch has pretty well described the pathogenesis of the undersurface posterior-superior cuff, but what about the slap lesion part of things? Here we need to understand a little bit about the throwing mechanics and again debunk a myth. When I did this review of throwing mechanics, it involved over 200 papers in the biomechanics of baseball throwing literature. There's very little been done on handball throwing. It turns out though that the little that's been done says that the similarity is at release across all of the sports. The trunk ankle remains at about 100 degrees, and coaches and players will argue with you about this. The difference is they have a lower amount of total external rotation range compared to baseball pitches. So what the coaches will say is, no, this is not the case. Some people throw like this hard, some people throw like this hard. This angle stays the same, and what they actually do is vary their trunk position. So when you throw hard, I can throw gently like this, and I can throw gently like this, but if I really want to throw hard, I have to get my arm to 90 degrees. So this is a particularly spectacular example of it. So at high speed, it looks like his arm's up here, but you can see he's actually positioning his trunk in that position. It's at about 100 degrees is where they do it. That's why we need to do the relocation sign also at about 100 degrees. So wait a minute, what about the relocation sign? Surely that says the head of the humerus is coming out anteriorly. Well, I disagree. What I think is happening and taking the pain away is we're not just pushing the head of the humerus posteriorly, we're changing the angle of horizontal abduction. The scapula is moving as well as the humerus. So what happens here is, if that damaged bit of cuff has folded into the joint, and I push all of this back, it goes out of the joint, and that's why it takes their pain away. That's why the relocation sign is positive on these guys. The slap lesion is another one we need to consider. The slap lesion might happen in some people by direct traction on the long head of the biceps, but it's not the case in throwing athletes. What happens in throwing athletes is it's related to the amount of rotation. And because the long head of the biceps is trapped in the bicipital groove, when you externally rotate, the biceps anchor here at the superior labrum is effectively being pulled off with this rotation. Now imagine what happens if this head of the humerus also translates posteriorly at the same time. The amount of tension on that long head of biceps anchor is what is the essential lesion that's going to generate our slap tear. So it's this amount of this rotation backwards and forwards which is actually pulling the long head of biceps and the associated superior labrum off. You can also see why lots of these guys are also going to get pathology at that proximal end of their long head of biceps through direct mechanical compression, be it to the sheath of the biceps or the biceps tendon itself. Right, with that in mind, I've now got an injured thrower in front of me. He tells me it hurts when he throws. What do I need to ask? I need to ask him about his throwing pain, and critically, I need to say, does it hurt before you release, or does it hurt after you release? And then once we've got that, we don't have time today, but we can go into difference later between cocking phase and acceleration phase in the before ball release. We then need to examine rotational range and strength. So for these guys, cocking phase problems are the ones that they'll actually come to you with, because cocking phase problems will result in a reduction in the velocity of their throw, and the pain is probably a little bit higher. For these guys, we need to check especially their external rotation range of motion, and to confirm our diagnosis, the relocation sign. Unfortunately, I think it's these deceleration related injuries that happen first and cause the cocking phase ones. Unfortunately though, if I can do all of this with no pain and then let the ball go and I only have pain, but I still throw the ball just as hard, the culture of the sport is, it hurts, but I can still play, so that's okay. So they don't come and seek your help when they have a deceleration-related injury. So when their velocity is injured, then they're in trouble. When their velocity is okay, they're not going to come and talk to you. And this is the thing we have to change in the culture of the sport. Now, rotational range of motion, there's three parts we need to look at, both internal and external, as well as the sum of the rotational range of motion. To understand this completely, and here I'm indebted to some research, one of the few bits of research that was done in handball players, and strangely enough published in one of the American journals. And if this guy was here, I'd love to meet him and shake his hand, because after reading this paper, it sent me on the path that let me get a PhD. Dr. Piper looked at the amount of torsion, or the twist in the long axis of the humerus in handball players, and he showed that in all of his handball players who'd thrown throughout their growing years, that they had an increase in this amount of twist in their humerus. And this twist, of course, affects the rotational range of motion. Unfortunately, to measure it, he used an X-ray, and he used this external gantry system, which is really hard to do clinically, and we definitely can't do it on adolescents, at least not in a screening way. So what we did after a period of time was figure out a way to do this using ultrasound. And so our ultrasound method of doing this, I should take a step back and tell you why this matters. Why humeral torsion matters, or this variation in the amount of twist at the humerus, is that it effectively shifts your rotational range of motion. So with the shoulder joint in the same position, if we vary the amount of twist about the long axis of the humerus, someone who's more retrotorted, like that, will look like this guy. It seems like he's got more external rotation, but he's lost internal rotation. Someone who's more anti-torted, and that's that, will look like this guy. So it effectively shifts the rotational range of motion. Retrotorsion, external. Anti-torsion, internal. The way to measure it that we figured out to do it, which we're pretty proud of because it turns out it's more accurate than CT scan, there's no ionising radiation, and it's really quick to do. And this is how long it takes to do the entire thing. As you saw, you need to put a spirit level on your ultrasound head. You then need to find the bicipital groove, which even I can find in the shoulder. Now, once you've found the bicipital groove and the long head of the biceps, you just go proximal and distal until you find the adjacent greater and lesser tubercles at their maximum height. I now then make sure that my sound head is level while this guy rotates until these guys become level inside your screen, and then we just measure the angle of inclination of the forearm. The last trap is make sure you put this firmly up against the ulna, and then you just read off the angle of inclination. When we did this, we measured the first 220 or so subjects. We found that there's a huge variation between people. Between our subjects, we saw a variation of 74 degrees with the shoulder in the same position. Within one subject, we saw a maximum variation of 45 degrees of rotation. So we can't just go and look at the other arm and say, okay, that's normal for you, that's what you should have on this side. We need to account for that difference in torsion. So for the acceleration-related injuries, passive external rotation range of motion, and clinically, how much they've got will predict for you how hard they can actually throw. So if they can only get to here, they can't throw at all. Their percentage of their total external rotation range from here will roughly tell you how hard they can throw. And this is really useful clinically to be able to return them to throwing prior to getting back all of their rotation range of motion. Deceleration-related injuries, we want to think about the posterior capsule. So we want to look at internal rotation range of motion and strength of the external rotators. I prefer to measure it in this position, stabilising the scapula, and measure until end of range. And again, compare across to the other side. We talked about flexibility, now we need to talk about strength, and after a lot of trial and error, we find that this is the best way for us to measure strength for the throwing athletes. With a handheld dynamometer, flex to 90, the guy knows I'm going to try and beat him. We do 3 tests that are a shallow range eccentric or a break test, and I just keep the best score out of those 3 trials. The resistance is being placed in line with the ulnar styloid process, and then do exactly the same process for external rotation. We've done that now on a few thousand people, getting close to 3,000 or 4,000, I think. For the first 500 or so injured people, we found that the healthy arm compared to the injured arm, we had a difference in the ratio of internal to external rotation. And there's a cut point at about 1.5 where this will tell us the difference between the injured and the uninjured guys. This is for all injured subjects. When we split that up into throwing athletes and normals, we find a different pattern in the throwing athletes in their ratios compared to the non-throwing athletes. The healthy side stays the same at less than 1.5. The throwing athletes have a higher ratio, largely because they have a higher internal rotation strength compared to the uninjured side. And also they're stronger on average than the average people. Normals have a lower strength in both internal and external rotation. So the way that you would employ this clinically is I can say that, look, the median strength might be like this for internal rotation and external rotation, but if the guy you've got in front of you is smaller or larger, these strengths might be higher or lower, but that ratio should stay the same. If somebody then comes in and the strength, for example, on internal rotation is like this, but external rotation is like that, we can use that relationship to say, well, your external should be up to here. Right now it's here, we'll call this 0%, and this is one of the things that we're going to track as you get better. And clearly we need to restore that external rotation strength, and we need to get it back to at least this position here. So tying all this together, This is actually the screening from our national team, and we break it into two parts, the flexibility part and the strength part. So each one of these subjects, firstly we need to look at their total rotational range. And you see there's a large variability. About 170, I think there might be a 160. About 170 is the smallest, 260 is the largest. Then when we know that total rotational range, we can say, all right, what's the difference from your throwing to your non-throwing side? This guy has only 3 degrees, basically no difference in rotational range of motion. This guy's got 30 degrees less rotation on his throwing side. If we know the torsion, we can then split it up and say, okay, this guy, only 3 degrees difference, but he's got 10 degrees more internal and 13 degrees less external. So now restoring our flexibility is simple. For strength, we find it best to normalise to body weight, and for the throwing athletes, the internal rotation is going to be somewhere between 20% and about 30% of their body weight. We measure it in kilos. External rotation should be about 2/3 or more of that. And from that, we can set up some rules where we say, well, these are guys that we need to watch out for these particular strengths, and this one, clearly something's going wrong. And then we want to look at that ratio. So this guy, most of the team's okay. These two guys we might check on, and this guy clearly we want to have a close look at. Getting the guys back to throwing. Last two things to talk about. Return to throwing. In baseball, it was really simple because for over 30 years now, we've developed these interval throwing programs. And if I just take an example here, at stage 4, the players make 25 throws over 25 feet, 50 at 60 feet, and finally 25 at 90 feet. They have to prove that they can do a stage painlessly, no trouble, before the following day they could come out and throw at the next stage. And by doing this stepwise progression, going towards the end where they make 25 long, hard throws, then we know that they're ready to go back to training. Handball, I'm not so sure, mainly because I've only been about 5 years with the sport. I think the distances need to start at about 5 metres and finish up at about 30 metres, so from here out to about there. And I think in handball, we need to be making, in training, somewhere between 25 and 50 hard throws. The soft throws, the gentle throws don't count so much. When do we say, forget it, I couldn't fix these guys? I think if there is a true symptomatic slap, long-headed biceps, and we really addressed all of the modifiable factors, it's time to go back and talk to our medical colleagues. Or if there's a co-pathology, again, that it's symptomatic and we haven't done terribly much about. So none of this work could have been done without all of the help that I've had from our rehab department. Thanks for your time. As you like.
Do you have any questions? Take the microphone and
Get your mic set up over there.
Thank you for the presentation. Sorry, this is really loud. Just wanted to ask, in the returning to throwing, the phases, how long is usually each phase?
How long is each phase?
Yeah.
Okay, depends how careful you're being. So in a best case scenario with the throwing athletes, I would say, I want you to throw 2 days out of every 3, and I want you to spend 2 days at each stage. So that's a minimum of 3 days per stage, 9 stages, 27 days. But this is clinically hard to do. So that's best case scenario. Worst case scenario, look, we really have to be back inside a week. Okay, maybe we'll start you at stage 4, and you have to do each stage once, and then come back the next day and prove that you can do that. And so we'll go 4, 5, 6, 7, 8, 9, 6 days, and away we go. But that's really cutting it fine. It's okay?
Roman Zeil from Luxembourg. Hello, thank you for this nice presentation. I noticed that you measured the external rotation in the position arm at this side. Don't you think it would be more realistic if you would be doing it in the abducted position?
Yeah, it certainly would mimic more what's going on in the throwing motion, but for the first 100 athletes that we did this test on, We measured it by the side, we measured it at 90-0, and we measured it at 90-90. And it turned out that the correlations for internal and for external at all three of those were, let's say, 0.9. However, when I measure it here, and especially when I measure it here, I hurt about 1 in 6 of the players. And when I measure it, and this is on the good side, when I measure it down here, it's very, very rare to hurt anybody. So for practical reasons, here it works better. And then flipping it around the other way, all that I'm using this measure for is to say, is this injured or not, and is there a reduction there? So because it turned out that that ratio was able to accurately identify the injured and the uninjured guys, then I don't care so much that this might mimic more what's going on in throwing. This is just a clinical test that tells me that's your injured arm and it's external rotation that's reduced, or it's internal or whatever. I think they're recording it, so they probably prefer to use the microphone.
Sorry, I'm from the field, so I have the background of the strength conditioning coach and handball coach.
Sure.
It's really nice what you say here, and for me, I get it a little bit more clearly what happened to my shoulder maybe 20 years. But the thing is, I will ask you something what I'll ask every doctor here. It goes in towards injury prevention.
Yes.
This is what I'm most interested in.
I say, so the key for me was, you saw we did all of those measures on flexibility and strength, and after a lot of experience, and it's exactly the strength and conditioning coaches are the people we should have doing this, because if we can get the strength and conditioning coaches, teach them how to do these strength measures and these flexibility measures, and you guys measure this once a week is enough, but then you have the numbers to say, okay, this guy's whatever, his external rotation is going down. And when it gets to this threshold, I'm going to change his program. And when it gets to this threshold, I can't let him throw anymore until it gets back up. When we implemented this, we actually implemented it in water polo. We had a marked reduction in the number of throwing injuries by, rather than waiting until the guy turns up and says, now it's starting to hurt, if you see that the guy is starting to lose strength or lose flexibility, then of course we change and we add stretches or we add strength, but we can do targeted ones rather than just saying everybody does everything. Because in practice, the ones that you're bad at, you'll probably be bad at the strengthening as well when you're doing it in a whole of program kind of approach. So it's much better to get you guys doing it. I don't want to go to the gym every day and take these measures, but you're there already.
Hello there, Rod. Really very, very informative presentation. I just have a question. As physio, sorry, I'm a physio myself. As orthopedic physio or physios that specialise in outpatients, we always think of the core stabilisation along with the peripheral. Yep. So I don't know, were you thinking of any lateral sling-based treatment when you were looking at peripheral, like especially in deceleration, the core takes in.
Oh, absolutely.
So how does that, or how did that inform what you were going to actually do specifically on the limb?
Absolutely. So here, in the context of 20 minutes, we really had to cut to the chase. So where it's a little bit different is in a baseball thrower, and that's where I can do everything. I can wind up from here, I can land, and now I can follow through using my trunk, I can use everything else. But a handball player, the same as a volleyballer, because they're in midair when they do it, if I try and use all of that, I'm going to land on my face. So those guys can only follow through using their arms. We try and get them to use their trunk as well, but then it changes the way you land, so I'm going to have to land like that. And sometimes in the context of the game, that's not possible. Yeah. But yeah, you're absolutely right.
Thank you. One of the risk measure of shoulder pain or instability is a deficit of the external rotator muscle. But when the muscle, mainly infraspinatus muscle, is gone, what is your management or your?
Yeah, so perhaps you're talking there about a suprascapular neuropathy, and we see that mostly in our volleyball players, and we see it occasionally in these throwing athletes, and I'm not quite sure why it is the difference, and it's one of the things we want to work towards figuring out. Once you have a complete suprascapular neuropathy, it's very, very challenging, and I don't know that we have a good solution for that. So the only treatment there is prevention, and that's where it comes back to frequently taking these measures and identifying these guys before the nerve is knocked out. The sneaky thing about the suprascapular nerve is it has no cutaneous distribution. So if I injure my ulnar nerve, I'll straight away go and see the doctor because I get this horrible pain in my little finger. If I injure my suprascapular nerve, all I get is weakness in external rotation. And nobody tests this regularly, so you never notice it until the nerve is completely destroyed and all these other problems happen, and then it's too late. So the key is the frequent ongoing measurement for these guys and getting them to report things early.